Hello again. This will be our last chapter for week 1 and 2, and it is covering critical care of patients with respiratory emergencies. Now, when I spoke to your Med-Surg 3 instructor, I was told he covers this chapter pretty extensively in Med-Surg 3, so the topic we're going to cover are pulmonary embolisms. The rest of this chapter will be covered in your Med-Surg 3 class. So a priority concept of this chapter is how a pulmonary embolism would affect our gas exchange. And this is an interrelated concept of perfusion, clotting, infection, and skin integrity. When one of those systems fails, we unfortunately have a fail for the whole system. And this is where we run into issues with respiratory gas exchange. When most people think of a pulmonary embolism, they think of a blood clot. But the interesting part to this is that the pathophysiology shows that it's a collection of particulate matter that enters the venous circulation and lodges in a pulmonary vessel. And this can be any substance. It could cause this emboli. It could be a blood clot, which is the most common, but it could also be a little bit of a fat that is covered with cells. It could be a foreign body that blocks some of our gas exchange. So pulmonary embolisms is that collection of particulate matter. It could be a solid, a liquid, or even air that enters that venous circulation and lodges in that pulmonary vessel, making the gas exchange inadequate, if not completely stopped altogether. Some risk factors for pulmonary embolism are a patient with prolonged immobility. You'll see these in our patients who are in the ICU or our patients who have had a traumatic spinal cord injury, any of our patients who have contractures, they are all at risk for that PE. The insertion of a central venous catheter leads itself to a pulmonary embolism because we are actually taking that catheter, we're sticking it in the artery all the way down to where the heart is. Anyone with surgery, we are taking the exterior and putting it into the interior. We run that risk of having foreign bodies lodged. Pregnancy is also a risk for PE because our body is going through so many changes and trying to grow a baby, as well as trying to maintain the homeostasis of the mother. Obesity is another risk because, again, that impairs that mobility, but also makes it to where circulation can be impaired in the legs and lower extremities. Advanced aging is also a risk factor for PE because, again, they are not as mobile as, say, a younger individual. There are general and genetic characteristics that can cause blood clotting. In our chapter, we talk about factor 5. If a patient has a history of a thromboembolism, they are at higher risk for an embolism because their body is already prone to producing them. COVID-19 was another one where we saw a lot of PEs developing. It definitely started hitting the cascades on the clotting ratios, and unfortunately a lot of those patients would survive COVID and then die of something like a pulmonary embolism or a stroke. Infection is another one where we have an accumulation of bacteria and white blood cells that are blocking what could be our respiratory flow, and so therefore could cause a pulmonary embolism. I apologize for this. I know it's going to seem like I hit on smoking cessation often a lot, but it's super important when we're taking care of our patients to discuss that because that is one of those preventable factors for pulmonary embolisms because it, again, causes the constriction of those blood vessels, which then in turn makes the narrowed passageways and things can get lodged. We can also reduce weight. That's another lifestyle change. Again, if we have obesity, that lends itself to not allowing proper blood flow to our lower extremities. Becoming more physically active, that gets that blood pumping, so hopefully that helps with our oxygen exchange. If you're traveling, you want to make sure that you're getting plenty of water so you're not dehydrated, which would increase the blood concentration of electrolytes and anomalies. We want to make sure we're changing positions often. We don't want to be sitting in a place for a very long period of time. Getting up from a sitting position 5 minutes for every hour is a good idea. You also want to avoid crossing your legs. I know as a young girl I was taught that that was proper to always cross my legs. And it's a hard habit for me to break off, and I still catch myself doing so. But when you cross your legs, you actually are blocking the blood flow to the leg that is crossed. So it actually can put you at risk for a pulmonary embolism. Now, in the previous slide, we did talk about HRT with smoking cessation. And if you don't know what that is, that's hormone replacement therapy. So we'll see that in our patients who have had breast cancer and are now on hormones so that they don't go into menopause. But we'll also see that in our patients who are on birth control. So if you are a young female, you're on birth control and you smoke, you are at a higher risk for stroke and pulmonary embolism related to that constriction of the blood vessels. When we talk about the assessment, we're looking at that physical signs and cues. We'll look at that respiratory system, that patient who is now struggling to breathe, who was just fine a moment ago. We'll look at cardiac. We'll see an increase in pulse and blood pressure. Psychosocial, that patient will be super anxious. A lot of times they'll have this, what they cue in as impending doom feeling. We'll see that low CO2 on the ABGs and general metabolic panel, troponin, BNP, and a D-dimer will all be impacted. We might do some imaging to assess whether or not this is a clot that can be broke up with TPA. So they'll actually take that patient for a CT scan to see where that blockage is actually occurring. So on the previous slide, we noted that the initial sign and symptom for a physical assessment was that cardiac heart rate and pulse will jump up. When we start progressing through this pulmonary embolism diagnosis, we'll start seeing that that patient has a low blood pressure, and that's in regards to our body trying to compensate for not having blood flow. We'll see hypoxemia. We'll see that potential for excessive bleeding, and that kind of comes with our curative. So when we treat this patient, if it's a clot, we break it up, then that patient runs the risk of bleeding because we have taken away their ability to clot. So we've talked about how to recognize a patient has a pulmonary embolism, what are some risk factors for a pulmonary embolism, and what that patient initially presents with. They're moving on to that secondary stage. Now we're going to talk about how to fix that problem, how to take action, what to do to try to help our patient through this difficult time. So we're going to manage the hypoxemia by applying oxygen. We want to try to keep the oxygen saturation of 90% or greater. We want to elevate that head of the bed. Again, that helps with the work of breathing. We want to recognize the signs of a PE and potentially, if the hospital has it, alert a rapid response. We need more hands on deck. I want to get those labs. I want to get that CT. I want a doctor present, and I need it right away so that I can try to manage any problems with this patient that could lead to a cardiac arrest. I want to manage that hypotension. We're going to do that with things like vasopressins. We want to give IV fluids to start to see if we can't help them in that way. And then again, if that doesn't work, we're moving to the ICU. We're getting them on medications to maintain that blood pressure while we're treating the blood clot itself. We're going to minimize bleeding with drug therapy. So again, this is that one part where you're kind of contraindicated. What do we do if I give a clot buster? I can't give my patient something that's going to cause clotting because, again, we don't want them to have another PE. So we have to treat them therapeutically and just monitor and make sure that they are not having another issue in regards to our treatment. So something you're going to find out about me is I like to try to end on an optimistic note. When you have a patient who comes in for a pulmonary embolism, my hope, my wish is always that we can get them through that state and they don't end up having critical issues such as cardiac arrest or respiratory arrest and passing away. When I do get my patient through those states, the next thing we talk about is that care coordination or transition of care. So if my patient came in with a pulmonary embolism, let's use the example of the young female on birth control, maybe smoking cessation. Maybe she went on an airplane and was sitting in a seat because she was going to Europe, and so her flight was very long, and when she got to the airport in Europe, she noticed that all of a sudden she had some pain in her chest and she was having a hard time breathing. So she went to a hospital, found out that she had this pulmonary embolism. If they were able to treat that with the blood thinners, she may be on some long-term blood thinners for the treatment of this. Is that something she can manage on her own? Potentially with the proper education. The other thing we'd want to look at for this one is she requiring oxygenation once the clot has been dispersed? For someone of young age, if it's treated rapidly enough, a lot of times they don't have those long-standing issues, so we are able to get them weaned off the oxygen and back home. Now, if we're presenting with someone with multiple comorbidities, someone with COPD who comes in, they've been inactive at home, let's say it's a 70-year-old male, they unfortunately just had a bout of pneumonia, and now all of a sudden they're having difficulty breathing again. They also have a PE. That patient, we treat them with the heparin, we treat them with the antibiotics, we get them through that recovery phase, but it may take them a while to where they're not needing that additional oxygen. So that patient may need to go home with oxygen, and we would discuss home care for them. Maybe they have some increased weakness, less ability to care for themselves. So again, two different presenting patients and how we might treat them to make sure that we are honoring their transition. So again, I presented two different kinds of patients. You have your patient who had COPD and your patient who had a long flight, smoking, and birth control. When we're evaluating that care of that patient, we're doing that on the basis of what that priority patient problem was. Then we look at those outcomes. We're making sure that we attain and maintain adequate gas exchange and oxygenation. We want to make sure that they don't experience hypovolemia or shock. We want to make sure that they don't end up having arrest. We want to make sure that they remain free from bleeding episodes because, again, a lot of times with a pulmonary embolism, our treatment is blood thinners. So we want to make sure that they are not having adverse effects to that. Just like before, these are our case studies. We're going to be reviewing these in class, but I also wanted to give you like a little bit of time to review them before class starts. That way you can come with questions and we can have a more fruitful discussion. Thank you.